Hello everyone. In this class, we'll study about surfactant and compliance. Surfactants. It is a lipid surface tension lowering agent lining the alveoli. If you see the composition, it is made up of protein lipid complexes and it is made up of mainly dipalmitoyl phosphatidylcholine, that is DPPC. Lipid along with other lipids, that is phosphatidylglycine, phospholipids, neutral lipids, and proteins. So this is the composition of the surfactant. It is mainly made up of dipalmitoyl phosphatidylcholine, that is 62%, phosphatidylglycerol 5%, other phospholipids 10%, neutral lipids 13%, proteins 8, and carbohydrate 2%. Synthesis of surfactant. Surfactant is produced by type 2 alveolar epithelial cells. Laminar bodies containing phospholipids are formed in these cells are secreted into the alveolar lumen by exocytosis in the form of tubes of lipids called as tubular myelin. The lipid later converted into phospholipids, which is the major constituent of surfactant. The surfactants are taken up by the alveolar macrophages. Some of the protein lipid complexes are taken up by type 2 alveolar cells and they are recycled. Formation of the phospholipid film is greatly enhanced by the proteins in the surfactant. This material contains 4 unique proteins: SPA, SPB, SPC, and SPD. This is the diagram showing the synthesis of surfactant. It is synthesized in the alveolar type 2 cells where they are mainly the phospholipids containing structures which are called as laminar bodies, and these laminar bodies are exocytosized from the alveolar type 2 cells, and then they later form the tubular structure which are called as tubular myelin. So then lipids which are secreted, they will form phospholipids which are important constituent of the layer, surfactant layer, and so then tubular myelin with phospholipids, they are going to form the surfactant layer, and some of these structures are they are phagocytosized by the alveolar macrophages, and some of the substances they are recycled by the alveolar type 2 cells for the formation of the new surfactant material. Factors affecting synthesis of surfactant. Thyroid hormones increase the production of surfactant. Glucocorticoid influence production and maturation of the surfactant. Insulin inhibits the synthesis of surfactant, where smoking reduces the surfactant production. Functions of surfactant. It is important for reduction of surface tension. According to the law of Laplace, in a spherical structures like alveoli, descending pressure equals to 2 times the tension. The T is surface tension on the walls divided by the radius. So the pressure is given by 2T divided by R. Surface tension due to the intermolecular attraction between the surface molecules, and thus it tries to reduce surface area and collapse the lung. Hence, this surface tension must be reduced, especially during expiration, otherwise lung will collapse. Surface tension is the inward force. Therefore, with the P constant, if the T is not reduced as R is reduced during expiration, surface tension may overcome the descending pressure, then the lungs will collapse. But in lungs, with the reduction of radius, there is a reduction of surface tension by surface tension lowering agent called surfactant. Surface tension is inversely related to the concentration of surfactant per unit area. Surfactant molecules are spread apart as alveolar size increases during inspiration but becomes closer during expiration, thereby adjusting surface tension during breathing. Its action is more effective during expiration than during inspiration. Surface tension between the fluid and the air is 7 to 14 times more than between the surfactant and the air. It is important for the maintenance of stability of the alveoli. Surfactant reduces the surface tension so that alveoli do not collapse. In absence of surfactant, air will tend to move from smaller alveoli, where obviously the pressure is more, to large alveoli where pressure is low, leading to collapse of the small alveoli and distension of the large alveoli. Surfactant also helps to prevent pulmonary edema by reducing surface tension. Surfactant keeps alveoli dry and thus helps in the exchange of gases. This diagram showing with the no surfactant, when the radius of the one alveoli decreases, there is an increase in the pressure and the air tends to move in the other alveoli, making the other alveoli distended. But with the surfactant, though there is a reduction in the pressure, radius will not be reduced, and thus the air will not eventually move into the other alveoli as rapidly as it is seen with the no surfactant. Clinical significance: infant respiratory distress syndrome or hyaline membrane disease. Infants, especially premature and infants born to diabetic mother due to the hyperinsulinemia, have a deficiency of surfactant in their alveoli and there is increased surface tension. Surfactant normally appears at the 28th week of gestation and mature just before 36th week. After birth, the infant makes several strong inspiratory movements and the lung expand. Surfactant keeps them from collapsing again. So deficiency of surfactant causes both collapsing of alveoli in many areas, that is called as atelectasis and pulmonary edema. The other factors that cause infant respiratory distress syndrome are low levels of thyroid and glucocorticoids. And during fetal life, chloride is secreted with fluid by pulmonary epithelial cells. At birth, there is a shift to sodium absorption by these cells via epithelial sodium channels, and the fluid is absorbed with the sodium. Prolonged maturity of epithelial sodium cells contributes to the pulmonary abnormalities in IRDS. Patchy atelectasis, seen in patients who have undergone cardiac surgery, during which a pump oxygenator is used and the pulmonary circulation is interrupted. Coming to compliance, the change in the lung volume per unit change in the airway pressure, that is delta V divided by delta P, is the stretchability or the compliance of the lungs and the chest wall. So where V is the volume of the lung and P is airway pressure and the delta is the difference, and usually compliance is expressed as a liter per centimeter of water. Some of the factors influencing compliance, that is the elasticity of the lung, changes in the lumen size, surfactants and surface tension, blood supply, interdependence, chest wall size, shape, deformity, infection and nerve damage. The compliance is studied under two headings: compliance of the lungs only and the compliance of the lungs and thoracic wall. Compliance of the lung: the extent to which the lung will expand for each unit increase in transpulmonary pressure is called as lung compliance. The normal value is 0.2 liters per centimeter of water. Compliance diagram of lung relates lung volume changes to changes in transpulmonary pressure. So there are two curves in this diagram: the inspiratory compliance curve and expiratory compliance curve. And this is the pleural pressures, change in the pleural pressure with the increase in the lung volume. Okay, so if you increase the pleural pressure, and that is going to increase the lung volume, and if you decrease the pressure, the lung volume is going to decrease with the respiration. The compliance is slightly greater when measured during the expiration than in inspiration. The compliance is determined by mainly the elastic forces of the lung tissue itself, which contributes about 1/3 of the compliance, and the elastic force caused by the surface tension of the fluid that lines the inside wall of the alveoli and other lung uh, air spaces, which contributes about the 2/3 of the compliance. The elastic force of the lung is determined mainly by the elastin and collagen in the lung parenchyma. Compliance of lung and thoracic wall. It is the compliance of entire pulmonary system. It is measured while expanding the lungs of a totally relaxed or paralyzed person. To inflate this total pulmonary system, almost twice as much pressure is needed as to inflate the same lungs after the removal from chest cage. The normal value is 0.11 liter per centimeter of water. It signifies that when there is an increase in airway pressure by 1 centimeter of water, then the volume of the lungs inside the thoracic wall increases by 0.13 liter. Note that the curve is shifted downwards and to the right, that is, compliance is reduced by pulmonary congestion and interstitial lung fibrosis or pulmonary fibrosis, where there will be stiffening and scarring of the lung tissue. The curve is shifted upwards and to the left in emphysema, where we say the compliance is increased. So this is the diagram showing the relation between transpulmonary pressure and increase in the lung volume. So this is the normal curve, whereas it is shifted to the right side in fibrosis, where there is no much expansion of the lung occurs with increase in the transpulmonary pressure. And the curve is going to shift to the left side in emphysema. Specific compliance. Compliance with reference to the lung volume at which it is measured, that is the FRC, is called as specific compliance. So specific compliance is equal to compliance divided by FRC, that is functional residual capacity. Specific compliance is used to compare the compliances of lung of different sizes. In individuals with having only one lung, the lung compliance is approximately half of the normal compliance. Similarly, in children, because of the smaller lung volume, compliance will be below normal in spite of the normal distensibility. This confusion is removed with a specific compliance, since FRC is proportionately reduced and specific compliance remains essentially constant. This is in brief about the surfactant and the compliance. Thank you.